So we are going to move to the next section, and that is Dr. Mello, and then we were going to take questions for all these sessions in the morning after that. But it's my pleasure to introduce Dr. Michelle Mello, who is in the back. There she is. Dr. Mello is a professor of law and public health at Harvard School of Public Health. She's also a member of the Institute of Medicine. She's one of the nation's leading researchers in the field of medical liability, specializing in empirical investigations of the performance of the medical liability system, and has done studies in this country and abroad. Dr. Mello is going to be presenting some of the preliminary data from the CARE study that we began in December of 2012. Michelle?
Well, I want to begin by acknowledging the folks who helped put together the data snapshot for you today, and foremost among them is my research assistant, Lena Kuznetsov, who's here, who many of you know from working with her on data entry. Also, Melinda and Suzanne Dodson have been really crucial in helping us understand what we're seeing in the data. And finally, we wouldn't have these data without the very dedicated work of all of our risk managers on the ground. So what I will be presenting today are interim data. The theme of this project is transparency, and we want to be transparent about how the program is going, but there's a couple caveats to keep in mind. One is that we're always refining the data itself. When we see anomalies in the data, we're constantly talking with folks on the ground to try to update and make sure we have a full sense of what has happened in each case, and there's certainly some of that still going on in our data set. And secondly, we're still going in accruing cases, so these are still early days for the program. So just bear that in mind as we begin to explore some of the preliminary themes and understandings for what's going on here. We're going to have an opportunity, I think, at the end of this session to ask questions, so if you wouldn't mind holding those until I finish, then we'll be happy to do that. And I'd like to involve Melinda and Suzanne and the risk managers also in answering some of the questions that may pertain to the why. Why are we seeing what we're seeing here? Just as a reminder, these are the trigger criteria for an event to come into our database here. So what we're looking at here are significant harm events, things that cause at least significant temporary harm, as well as those that involve permanent harm or death. And then there are a number of trigger criteria that don't relate to harm. So events can come into our database if they are otherwise reportable to the Board of Medicine or the Department of Public Health, or a provider requests that the CARE program handle his or her event, whether or not it meets the severity criterion. Or we receive a pre-litigation notice at the hospital relating to an event. Another nuance I want to point out with regard to the harm definition is that we're trying to incorporate the patient's perspective about the severity of harm here. And there are certainly events that hospital personnel would not code as a significant harm event, but they get in if the patient reports it as having reached that level of severity. So in the patient's view, it has. This is what our current case volume looks like. We've got 448 cases that are currently open or closed in our database. And you can see here that they're contributed by 4 of our 6 hospitals. 2 of the very small hospitals are not contributing to this data collection effort. But the majority come from Bay State's main campus, that's BMC, and Beth Israel's main campus here. So Beth Israel has been reporting events to our database at the rate of about 13 per month, and at Bay State it's slightly higher, around 16 per month here. And here's what the progress of cases looks like today. So one thing to note here is that about 70% of the cases that have opened since early last year have closed at this point, and that's consistent with what Ken just told you about how long it typically takes to work a case through the system. About 12% of the cases in the database that have reached a determination point have been referred on to the CARE Insurer protocol. So again, as Ken intimated, this is mostly a program that concerns itself with events that don't reach those trigger criteria of a standard of care violation and significant harm and causation. In other words, it's primarily a program of explanation and resolution for cases that did not involve potential liability for the hospital. The third thing to note about this slide is we've got relatively few of the care insure cases that have closed at this point, just 24. So we're really constrained in our ability to comment very much on how the insurers are handling these cases, although we'll have a few things to say about that relatively small number of cases. The characteristics in terms of injury severity of our sample are presented here. The things to note here, I think, is that we're dealing with a pretty high proportion of events that involve temporary harm. It's still significant harm, at least in the eyes of the patient, but it's only the light blue and the orange slices of the pie here that involve permanent harm or death events, the kind of events that people might classically think about an early resolution program as being primarily concerned with. We're dealing with a lot of more minor harms. The message from this slide, which shows both the primary and secondary involved provider, is that the involved providers are overwhelmingly attending physicians. So here the risk manager was asked to report who was most involved in the adverse event itself and then who was secondarily involved. And we do see nursing involvement here in a fair proportion of cases, but overwhelmingly it's attending physicians. We don't see a lot of events, for example, involving trainees. Some good news here in terms of the care program's effect on reporting. Over 2/3 of the events that come into our database come to us from an internal reporter, a physician, a nurse, or other patient relations risk, somebody within the hospital detects and enters this event into the system. Very rarely do we see surprises coming in from attorneys or insurers, who we assume hear about them from attorneys. And there are a fair number of patient-reported events here, but it's important to bear in mind a lot of these would be, again, things that the patient perceives to be an adverse event, but that the provider or the hospital would not characterize in that way. Either it is, some product of the patient's underlying disease process rather than related to medical care, or for some other reason is an event that even an alert provider who was fully compliant with their reporting responsibilities would not have reported as an adverse event. So now we're beginning to get into what happened in the cases that were reported into our system. One thing we've asked risk managers to tell us is what proportion of these events received an initial disclosure conversation. And so this would be the conversation that takes place within 24, 48 hours after the event, where the goal is to say something unexpected happens, here's what we know with reasonable degree of certainty about why it happened, and here's what we're going to do about it, if anything, going forward. What we see here is these are just closed cases. We don't want to report cases where we're still trying to understand what's going on. But among these cases, in over 2/3 of them, we see that at least an initial disclosure conversation took place. Now, there's some things that I want to point out here about the limitations of the data that are really important. And one is that a lot of these cases where we're seeing an unable to ascertain, very likely that's a documentation issue. Particularly at one of our major contributing sites, the folks who enter our data are very reliant on the medical record. And if the provider himself or herself did not document that a disclosure conversation took place, that would likely show up here as an unable to ascertain. But it's our belief that in these cases, disclosure actually is fairly routine. The other thing we see is with regard to the proportion where we don't have disclosure conversations, where it's marked as a no, the risk manager's belief is that in a high proportion of cases, these are, again, the type of events that appear from the patient's perspective to be an unanticipated care outcome, but the provider did not see it that way. So they don't believe that there's a large proportion of cases where there was an adverse event and there was a deliberate decision not to disclose. Rather, there's a difference in view about what happened and whether this is the type of harm that should trigger a disclosure. So now let me get into what the hospital determined when they investigated events. One of the important judgments that they have to make is whether the standard of care was violated. So the pie chart here shows our current data snapshot on that determination. And one thing to notice is that in a quarter of these cases, we still have work to do here. So there are about 57 events, I think, where we don't yet have a determination about standard of care. And then there are another 56 where our risk managers have coded this as unable to determine, but we've asked them to go back and look at those cases again. We think what that reflects is really a lot of gray cases where they really felt like we're never really going to know whether it was violated or not here. That may be so, but in our study, we're asking them to make the call, even if it's with a low level of confidence. So we asked them to rate on a scale from 1 to 6 their confidence that the standard of care was violated. So, so these green and light blue slices are likely to change over the course of the study. But among those that have been filled in, we have, if you just take out of the purple and dark green slices here, what the numbers work out to about 75% of these known cases are determined to be not standard of care violated, and 25% are cases where they say, yes, there was a problem with the care. And that is really remarkably consistent, again, as was the case when I reported last on these data 6 months ago, very consistent with what we see in other programs of this kind, that about 3/4 of the events are events where the care was deemed to be appropriate and the rest are not. So what I want to talk about first are just the cases where the hospital indeed determined in their view, there was not a problem with the standard of care, and that's 250 cases so far. So a few things to notice about what has happened in these cases. One is that the majority of these are deemed also not to involve an element of causation. So not only was there no liability from the hospital's perspective in terms of the negligence standard, but also there was just this basic requirement of causation not met. So these, for example, would be a lot of cases where what the patient is experiencing was determined by the hospital to be a product of their underlying disease or injury and not the medical care. As we'd expect, very few of these cases get referred to the care insurer protocol. As you'll recall, the trigger criterion for that are primarily that there is a significant harm event with causation and with a standard of care violation. The other trigger criterion for getting referred to the insurer is that there's a pre-litigation notice in play. And that's what you're seeing accounted for here in the few cases where the standard of care was met, but the insurer was still put on notice. There are a couple of other trigger points that we noticed in the few cases where the insurer gets involved here. One is that the risk managers are again in a very uncomfortable gray zone when their judgments about the standard of care. So they think the standard of care was met, but they will sometimes alert the insurer nevertheless that this is a case that they might want to have a look at. And then we have a few cases where we just have a very angry family and/or, again, this pre-litigation notice. And the risk manager's judgment is this ought to be referred on to the insurer for management for that reason. So I now want to switch and talk about another slice of the pie. What I'm characterizing here is 19% of all events that were determined to be cases in which the standard of care was violated. And this is, from many people's perspective, where the rubber hits the road in a program like this. But again, it's important to keep in mind from a macro view, this is a really actually quite small slice of cases here. So what happened in these 85 cases where the hospital thought there was a violation of the standard of care? Not all of these were significant harm events. That's the first thing to notice. Almost half of them were not significant harm events and wouldn't have been referred on to the insurer for that reason, because again, our trigger criterion requires significant harm. Among those that did meet that initial trigger, the second thing to notice here is most of them did also involve causation. So this 36 here, these are cases where we've got a problem with the care, there is significant harm, and the harm is related to the decisions made about the care. So the puzzle in this slide may appear to be, why is it that only 22 of these 36 then got referred on to the insurer? Because those cases would seem to have met all of the criterion for being referred on for consideration for compensation. So we did look at those cases, at the 14 that didn't get referred on, notwithstanding the fact that it seemingly they should have. And here were the most common reasons we saw. Essentially, we had hospitals reporting that they were able to achieve a satisfactory resolution with the patient on their own without involving the insurer. in a number of cases. Typically, this might involve extending service recovery of some kind. Sometimes it involved a judgment that the patient wasn't seeking compensation and or was satisfied with the apology and the explanation received. There might be an ongoing communication process that the hospital ultimately determined was satisfactory or so forth. In one case, we had a patient who just expressed a disinterest in participating in the care process with the insurer, and it wasn't referred on for that reason. And then in a few cases, we saw the hospital, sometimes with input from the insurer, making a determination for various reasons that compensation wasn't warranted. Again, notwithstanding the fact that we see on their face these trigger criterion was met. And so some of the reasons that we saw for that is, the harm actually was not very high, although it technically met this significant harm definition. It was not considered to be high enough to warrant that. Or what we saw more often was, again, this risk manager expressing the view, it was really hard for me to make the call about standard of care. This is a very gray case. I don't feel comfortable with the judgment that we owe money on this case. And so there's just lots of uncertainty around that. The other thing to notice about this slide is there are 4 cases where there was a referral to the insurer, even though it didn't meet the harm criterion or some other criterion. And these, again, were cases where there was concern because the patient or family was very upset and seemed inclined to sue. So there's not a strict identity between the neat flowchart that was presented before about the referral to insurer protocol and what happens on the ground. But there does seem to be substantial adherence, and I think what you're seeing here is some degree of sort of flexibility or judgment calls on the part of risk managers about which cases ought to be referred on when they don't technically meet the criteria, because there seems to be a liability risk here. And then still a little bit of a puzzle around some of the reasoning in cases that might appear to meet the trigger criteria. So what happens when the insurers get these cases referred to them? What action do they take? Again, this is really tough to present on because, first of all, many of them are still open. And then among those that aren't still open, there really is a diversity of responses that the insurers are making. But these are some categories that we sort of extracted from insurers' free text comments on what they had done with the cases. And what you're seeing here are the counts of cases according to whether the standard of care was violated or not. The ND is not determined. And then what particular action the insurer took. So some things to notice here are, although there are some factors that impede offers of compensation or service recovery being made quickly, for example, a non-participatory patient, there really are very few cases here in which the insurer was determined they were not going to pay in a case where the standard of care was violated. So there's 3 of those cases, and we actually looked at those cases to figure out what was going on there. In one case, the insurer disagreed with the hospital's initial determination. They thought that while there was a problem with the care, it was a problem with the ambulance and the transport, not the hospital. In one of the cases, it came into the study because there was a pre-litigation notice received, not because it was reported soon after the event. And the attorney was not interested in participating in the care process. And then in one, the patient called in a case, they actually called because they read our roadmap document that we produced a year ago and said, oh yeah, something happened to me in the past. They called this in, and to make a long story short, it's just not exactly clear what happened in that case yet. We're still trying to sort of figure that out because there seems to be some discrepant data. But in most of the cases in which the insurer gets these cases reported to them and they have agreed that there's a standard of care violation, we see them taking what would appear to be the indicated action in terms of a settlement or bill waiver offer. But it is interesting that patient factors contribute to an inability to execute on the vision of this process to some extent. If you have either a patient or family that is unwilling to participate, or an attorney is involved who doesn't seem to be inclined to engage in settlement negotiations at this stage, or the patient is simply impossible to reach. In lots of these cases we see risk managers noting we called 3, 4, 5 times, they never call us back, they don't seem interested in meeting. We looked also at what was communicated to the patient in the conversations that were meant to take place after the investigation was completed. So again, there's an initial disclosure conversation that is contemplated, but it's also contemplated that in some subset of cases, a more detailed investigation will be required in order to figure out what happened. And in those cases, the patient is meant to get a bookend conversation after that investigation where they're given feedback. So how often did that happen, and what was said in those conversations? What you see here is divided among cases that were designated as care insurer cases and those that weren't. And initially this is a sort of dispiriting slide to look at because it looks like the proportions are not as close to 100% as we would expect here. But again, there are a number of important things to recognize about why you would read the data, why you might read the data a different way. One is that the risk managers tell us in a large proportion of these cases that are non-care insurer cases, these are what they would categorize as known complication cases. They're cases where the patient did suffer a harm, but it was a harm that was not unexpected, certainly from the provider's perspective, and to some extent also from the patient's perspective. So an example would be a perforated colon during colonoscopy. A risk that is disclosed in the informed consent form would be routinely discussed in an informed consent conversation, but would still be something that would bum a patient out a lot when they awaken from a colonoscopy. That's the kind of event that is going to get an initial disclosure conversation, but there may not be any action following that would result in a follow-up resolution conversation. So the key elements that we would expect to see as part of a disclosure conversation, like apology or explanation, would have been provided earlier on upstream, and we wouldn't capture a second conversation in our data. Another reason we hear is that sometimes, again, a patient is difficult to reach or is unresponsive or unwilling to come in and talk about the investigation results. Risk managers also reported, particularly at one hospital, again, there's a problem of documentation because they rely heavily on the medical record, and doctors don't always document these conversations. It's possible that they're missing some. There were a few cases in which the risk managers actually judged it ethically inappropriate to recontact the family, feeling that it would burden someone who was not in a position to participate in this kind of conversation right now. And then there were many cases in which the investigation did not yield any additional information, and the risk manager made a decision that it wasn't necessary to call the family back in for an additional conversation, that she didn't really have any new information to provide relative to what had been given to them in the initial disclosure conversation. And in a related vein, in some cases, the hospital's investigation actually revealed to them in their judgment that there wasn't any causation between what had happened and the medical care provided, and for that reason, the risk manager decided not to pursue further contact with the patient. We looked in particular at 7 care insurer cases that didn't have a resolution conversation report recorded because those seemed like the most worrisome settings in which you would want to omit this conversation. And we found that in almost all of those, the reason given was that they had come in on a pre-litigation notice and the attorney was unwilling to engage in the conversation. There were 2 other cases, I think, that involved other factors, but primarily it was attorney-related factors that precluded a follow-up conversation with the patient. Finally, in those conversations that did take place, what did patients get told? Here I've divided them by cases in which the standard of care was violated and those in which it was met. And a few things to note here. The most important thing is, again, to remember that these are the post-investigation conversations, and many of these elements would actually have been provided upstream in the initial disclosure conversation, especially apologies. That would be a pretty routine part of that initial conversation, and so that may be the place where those are captured and not here in these data. But one thing that strikes me is we see that all of the cases in which compensation was offered were cases in which there was a standard of care violation. Some providers, I think, fear that these programs are going to settle cases out from under them in cases where they really didn't have any fault, and we don't see insurers sort of running off and making offers in defensible cases here. The other thing to notice is that in those cases that did involve a standard of care violation, money is only offered, whether it's service recovery or compensation in about a third of the cases. And that initially struck me as low. One of the explanations provided is we have to recall that the protocol calls for the awarding of money through the care and share protocol only when that significant harm criterion is met, and that would not have been the case for some, a fair proportion of those, or they may not have involved causation as well. So again, these cuts are just by that standard of care violation. So I'm going to conclude there. I know that's a lot to throw at you, and again, we have a Q&A period open now, and I'm going to again invite the folks on the ground at the hospitals who've been involved in generating these data to help respond to questions that relate to the whys of what we're seeing here. Thanks.